This is a very strange toy. But we're not talking about that now. Time for the neurodegenerative diseases. Seizures and seizure disorders. Okay. The classic thing when people think about when you mention seizures is epilepsy. But did you know that there are a lot of conditions that can cause seizures that are not epilepsy? Matter of fact, one of the principles that I really try to impart onto students is this idea of diagnosis by exclusion. Epilepsy, or uncontrolled, unprovoked recurrent seizures, is a classic example of diagnosis by exclusion. And what that means is when people present with these seizures, every other possibility is ruled out. So the workup here is really long. You got to scan the brain, look for masses, look for electrolyte imbalances, look for other diseases that are known to cause seizures. This takes a little bit of time, but in so doing, what essentially you're saying is, hey, once we've ruled out all these other things, epilepsy must be the diagnosis. But always remember, when your patients have seizures, there are many potential sources or causes of seizure or uncontrolled electrical discharge within the brain. So, investigate further. Does this person have an identifiable source for those seizures? If not, they may have epilepsy. There's two general terms you're going to kind of hear about when people are referring to seizures in the clinical setting, and that is focal and generalized. They're not that difficult to figure out. Focal just means that the uncontrolled electrical discharge occurred at a very specific portion of the brain. Generalized, as the name implies, means that the electrical discharge occurred all over the brain rather than in one specific site. So then your seizure categories kind of build off that knowledge of what is generalized versus what is focal. Start with your focal seizures. If you're having uncontrolled electrical discharge at one particular point in the brain, does it make sense that that would clinically manifest as something very specific in the body? Maybe just a portion of one limb is moving or demonstrating some seizure activity. So it's not generalized. It's the exact opposite of that. Now in focal seizures, one of the boundaries is the retention or loss of consciousness. And that's something as a clinician that you'll be expected to look for and document. When it comes to generalized seizures, there's all kinds of terms that you have to look at. Things like absence seizures, where people just kind of phase out. Seizures with tonicity or clonicity, and those are changes to muscles. Your classic Hollywood type seizure is your tonic-clonic seizure, formerly called grand mal, though that term is now considered antiquated. Surprisingly enough, some seizures don't comfortably fit into these categories and fall under the last category here. If you work with patients with seizures, they'll often tell you they have an aura. And an aura is this neurologic pre-seizure feeling that patients will get. And this can actually be a very helpful thing for patients to know about because it can alert them that a seizure is coming on and they can take measures to ensure their safety. Here's some more terms that apply to seizures regardless of the cause, whether they be organic, like a brain tumor, or something that can't be otherwise classified, therefore say epilepsy, a diagnosis by exclusion. The terms pre-ictal, ictal, and post-ictal refer to points in time along which the seizure occurred. So the pre-ictal state is that immediate before seizure time at which some patients will experience an aura. The ictal period is that point in time where the actual seizure is occurring, electrical discharge is going on in the brain, and there may be clinical manifestations that are a consequence of that. The post-ictal time, the electrical discharge has stopped, but that does not mean that the patient is back to 100%. In the post-ictal time, a lot of patients will feel tired, or fatigued, they may not have a return to their baseline mental status right away. Seizures are a byproduct of neuronal irritability, and a lot of things can irritate neurons. As we mentioned in the first slide here, electrolyte imbalances can irritate neurons in favor of seizure formation. One of the most common ones, and ones that you'll be expected to know clinically, is sodium and sodium level. Throughout your professional life, if a person's sodium balance falls too high or goes too low, seizure potential and seizure risk will be something that you will have to consider. So when patients have seizures, you're going to see the diagnostic workup really span the gamut of every possible cause of seizures. So that's going to include a complete blood count to look for, say, red blood cells and see how well oxygen is being delivered to tissues, including the brain. A serum chemistry, which includes things like sodium, potassium, BUN creatinine for kidney function, how well the body's excreting wastes. Liver enzymes, reflective of the liver's ability to filter out the blood. People with advanced liver disease can develop something called encephalopathy, which is an accrual of ammonia that can then potentiate seizures in patients. Brain imaging studies would be done to look for masses or things that could potentially irritate neurons as well and be identified as a source of seizures. As a person taking care of someone who has seizures, it's always worth remembering emergency seizure care and what to do after a seizure subsides. Thing number one, that whole myth that we learned eons back that a person would swallow their tongue, it's just a myth. Try it. Try swallowing your tongue. Can you swallow your tongue? Can you swallow your tongue? No? Keeping patients safe is the main goal here. In the post-seizure setting, rolling a patient to their side, something referred to as the recovery position, is done to prevent a complication of seizures, and that is aspiration of gastric contents into the lungs. I would be remiss if I didn't take a few minutes to mention kind of the worst case scenario of seizures and seizure activity. Status epilepticus. Status epilepticus is a seizure state in which the seizure is not self-limited, as 90+% of all seizures are. In this setting, the seizure is prolonged. And in prolonging the seizure, then, this can lead to inadequate respiration, changes in blood gas level, changes in consciousness, all kinds of detrimental, deleterious effects. Status epilepticus is a medical emergency. This person does not need to be observed and then monitored for safety. They need to be moved to a medical facility that has access to benzodiazepine medication to get them out of status epilepticus. Before I jump into meningitis, I just have to do the world's greatest say what you see puzzle. Look at my picture here and say what you see. You got it? Huh? How many of you said men in G's? Men in G's! I write my own jokes. Meningitis is, as the name implies, inflammation of the meninges. Nothing too cuckoo crazy about that. The usual suspects include strep pneumonia, Neisseria meningitidis, can't say that at all, and Haemophilus influenza. On the viral side, enterovirus, HSV, HIV are some of the viral culprits. You'll notice that this list contains both bacteria and viruses, and it's important to note that meningitis can be a product of either bacterial origin or viral origin. I will tell you right now, bacterial meningitis, much more symptomatic and mortality higher than viral meningitis. This is also a principle of cattle moment. Generally speaking, bacterial infections are more symptomatic and more serious than viral infections. Bacterial infections oftentimes need treatment with antibiotics. Viral infections oftentimes do not need to be treated with antiviral medications. They simply will run their course. This has been a principle of patho. So you might actually say to yourself, hey, isn't the CNS kind of like sterile? Absolutely. So colonization of somewhere else in the body, say the respiratory tract or the gut or somewhere else, had to have occurred for the most part prior to getting meningitis. Yes, you could say, what about, when my skull gets cracked and I get meningitis that way? Yeah, not that common. For the most part, meningitis cases, for the most part, are secondary to infection from other parts of the body. A very typical pathway would be in, say, the nasopharynx, the respiratory system, then into the bloodstream, from the bloodstream into the CNS and the meninges specifically. Clinical presentation for someone with meningitis classically contains a lot of different things, but most importantly, nuchal rigidity or a stiff neck. Oh man, this thing's really stiff. It's not moving at all. What's going on? I think I have meningitis. And the reason nuchal rigidity exists is because, remember, the meninges line not only the brain, but the spinal column as well. And as the meninges start to inflame, they get sore. And when a person moves their neck, they are basically aggravating inflamed meninges. Matter of fact, the two common assessments for meningitis, Brodzinski's and Koenig's, are both physical maneuvers meant to intentionally irritate inflamed meninges. So for a meningitis workup, you're going to see your patients getting some blood cultures to try to find causative organisms, and there's going to be examination of the cerebrospinal fluid as well. Sometimes the CSF will show an organism, sometimes it won't. If all cultures are negative and this person isn't all that symptomatic, you may hear the term aseptic meningitis. All that means is meningitis most likely of a viral origin. Now, while aseptic or viral meningitis can run its course, so to speak, and not necessarily require antiviral treatment, bacterial meningitis is very serious, and mortality for meningococcal meningitis specifically can be quite high. In addition, morbidity, or how much debilitation, including permanent debilitation, a person gets from bacterial meningitis, especially meningococcal, can be quite high as well. That is why bacterial meningitis, its three most common culprits, do have vaccines available. And I highlight this because this is an area for we as nurses to ensure that these health promotion types of activities, such as meningitis-appropriate vaccines, get administered to those in whom it is appropriate. I usually talk about encephalitis as it contrasts with meningitis. Meningitis, inflammation of the meninges. Encephalitis, inflammation of the brain. Yep, inflammation of the brain. Interestingly enough, though technically anything could cause meningitis, far and away, viruses are the most common culprits here. Far and away. Clinically, meningitis and encephalitis have a fair amount of overlap. So this is for you ER people here. One of your important distinguishing characteristics in terms of clinical presentation will be with regard to mental status and mental status changes, something that's more commonly seen in patients with encephalitis and much less common in patients with meningitis. Another thing worth mentioning here is something that we've kind of already talked about. Anytime there is an inflammatory process occurring in the CNS, remember our skull is a closed system for the most part. Inflammation leads to the collection of fluid and fluid edema, fluid shifts and whatnot. There's the potential for fluid retention in the skull, the potential for increased intracranial pressure, and we need to monitor our patients with regard to that and look for those clinical signs of increased ICP. I have a question, I have a question, I have a question, I have a question, I have a question. Yes, you, odd-looking student in the very back row, what's your question? What about West Nile virus? It's all over the place, right? Well, mosquitoes, they're carrying West Nile everywhere. How come all of us aren't walking around with West Nile encephalitis? Well, strange-looking student in the back row, I'd like to address your question. The fact of the matter is, many mosquitoes do carry West Nile virus, and it has been documented in areas of East Tennessee. However, the amount of persons infected with West Nile virus is relatively small. What's more, only about 1 in 150 people who are infected with West Nile actually become infected with it in a severe enough form to develop West Nile encephalitis. Relatively rare. Far more common to be infected with West Nile virus and either be completely asymptomatic or just minimally symptomatic. In addition to answering that question, one of the things I always do add when I'm talking about West Nile and West Nile encephalitis and all these kind of scary things that can be transmitted by mosquitoes is to mention that birds do act as a reservoir for this virus. So, that thing about seeing a dead bird somewhere and picking it up with your bare hands and chucking it, throwing it away, well, just be a little cautious. Be a little cautious. Cranial nerve 7 inflammation, more popularly known as Bell's palsy, is technically something for which we do not know exactly the path underneath, but we do have kind of viral suspects that continue to be studied for this. The trouble is, not everybody that has these viruses develops cranial nerve 7 palsy or Bell's palsy, so it's been challenging to have a real clear causative connection between one and then the other. In Bell's palsy, inflammation of the 7th cranial nerve creates facial paralysis. This then can be seen in the clinical presentation of facial asymmetry, asking your patient to smile and seeing asymmetry to the smile, asking your patient to raise their eyebrows, asymmetry with regard to that. When you're taking care of patients with Bell's palsy, one of the most important things to do for them and remind them to do at home is to take care of the eye that will not shut completely to avoid corneal dryness and things of that nature. Though some things have been determined with regard to risk factors for Bell's palsy, including a genetic predisposition, patients with diabetes, patients that are pregnant, unfortunately these have only been correlates so far. So we say, okay, this population has an increased risk for Bell's palsy, but we haven't been able to establish any cause and effect direct relationship yet. Another thing to mention with Bell's palsy is that it's kind of a diagnosis by exclusion, meaning when a patient comes in with facial asymmetry, they have to have a stroke workup to make sure they're not having a stroke. They have to make sure they're not having other things that could affect cranial nerve 7. Bell's palsy essentially is another diagnosis by exclusion. Rule out all the other possibilities and then hang your hat on Bell's palsy. And those list of things include things like otitis media, which are ear infections, Lyme disease from ticks, Guillain-Barré syndrome, HIV, and Sjogren's syndrome, an autoimmune condition that produces dry eyes, dry mouths, and sometimes facial asymmetry as a manifestation. Multiple sclerosis is a classic autoimmune disease characterized by remissions and exacerbations specific to myelin in the CNS. The degradation of myelin impedes the electrical potential through the axon and eventually it results in axonal degeneration. MS has many different subtypes. Some people's versions or subtypes of MS are more severe than others, and therefore their clinical courses will differ. Since there are different subtypes, the clinical presentation when you see these patients is going to be variable as well. Though it's not uncommon to see eye muscle changes, ataxia, which is a change in gait, and sensory changes that are variable around the body, but it can sometimes approximate things such as Brown-Séquard syndrome. Though we don't really know what causes MS, and we don't really have a proper understanding of the prior infectious agent that sets off this autoimmune process, Epstein-Barr virus is a suspect. But if EBV infection were the only thing, hey, we'd all have it because we're almost all exposed to EBV at some point in time in our lives. Some of us clear it, some of us don't. So perhaps there are genetic differences between us that increase or reduce our susceptibility to developing multiple sclerosis. Well, in MS research, over 200 polymorphisms have been identified that correlate to the risk stratification for the development of multiple sclerosis. Polymorphisms are naturally occurring genetic changes between populations that occur at least at a frequency of 1%. When you're working with MS patients, you may hear the term plaque or plaque buildup. And this is a term that you'll also hear when you work with patients that have dementia, especially Alzheimer's dementia. The diagnostic workup for these patients may indeed include imaging of the brain to look for brain structural changes that include MS plaques. These plaques are a byproduct of the chronic inflammatory changes that occur to the structural areas of the brain. When you're first learning about neurodegenerative diseases, it is so easy to flip-flop MS and MG. They are both autoimmune diseases, but the location of the autoimmunity very, very different. Myasthenia gravis is an autoimmune disorder affecting the neuromuscular junction where the neuron meets the muscle. Couple different subtypes. Most common is the development of antibodies toward the acetylcholine receptors at the distal aspect of the junction. Not the only version though. There's other versions of MS where the antibodies develop against what are called MuSK proteins that are another component of the distal neuromuscular junction. Though they may be anatomically close, technically the antibodies form to different structures within that area. Really interesting thing about myasthenia gravis was the discovery a long time ago of thymic changes in these patients. Thymic hyperplasia and or an actual thymic tumor called a thymoma. The reason I mention this is if you work with this patient population, you may find that many of them undergo thymectomies as part of their therapeutic option. When thymectomies are discussed with patients, the surgeon will be very clear. It's not a cure-all for everybody with myasthenia gravis. Roughly about a third of patients will see a marked reduction in clinical myasthenia gravis activity. Roughly a third, a minimal reduction, and then another third, almost no effect at all on their disease. Though MS and myasthenia gravis are anatomically different in terms of where the autoimmune process is occurring, Epstein-Barr is still being studied as a potential viral precursor to this condition. Now, what would be the difference here? Let's just play this out for a second. What would be the difference in somebody, say two people have Epstein-Barr virus chronically, one goes on to develop MS and the other goes on to develop myasthenia gravis. Think to yourself, what might be the difference between these two people? The answer probably lies in genetic susceptibility. One is genetically susceptible to one condition, the other genetically susceptible to the other. We are deep in the genetic age, and genetic susceptibilities are being published in the research literature all the time. When you work with these patients clinically, you're going to see a whole array of different degrees of muscle weakness. This is dependent upon where they are in their diagnosis, their disease trajectory, how well their medicines work for them, and kind of what subtype or severity of the disease they actually have. There actually is a subtype of myasthenia gravis that is completely ocular in nature. And eye weakness or extraocular muscle weakness is really the only clinical manifestation. Guillain-Barré syndrome. Guillain-Barré syndrome is the peripheral nervous system's version of multiple sclerosis, in that MS is a demyelinating condition of the central nervous system's nerves. GBS is a demyelinization of the peripheral myelin sheath. In our central nervous system, it's oligodendrocytes that produce the myelin sheath in the CNS. In the peripheral nervous system, remember from A&P, it's Schwann cells that produce myelin for those nerves. Now, though Guillain-Barré is preceded typically by an infectious process and looks in some respects like an autoimmune disease, in other ways it doesn't behave like a textbook autoimmune disease. Here's the main one. Your classic textbook autoimmune disease is characterized by exacerbations and remissions. In Guillain-Barré, patients will have it one time, it then remisses and never recurs. That's not a textbook autoimmune disease. So GBS is a little bit different than some of the other autoimmune diseases. But in GBS, it does typically precede an infection. Consequent to the infection, GBS develops. And we do have some infectious agents that have been studied that have been definitely, at least strongly correlated with eventual development of GBS afterwards. So, clinical presentation of GBS almost always starts with kind of a peripheral change to sensory nerves or a numbness and tingling, that's paresthesia, some type of change there, and it has this ascending paralysis type of feel to it. So patients will tell you, well, something earlier in the day it started in my toes, and then by about afternoon, the sensation loss was up to my knees. By nighttime, I was having trouble feeling and moving my legs in this kind of ascending process. Starts in the arms too, with the fingers going up the arms. And after a day or a couple days, there is complete paralysis because of the effects of the peripheral myelin sheath. I got a question. Yes. Odd-looking student in the back row. What questions do you have? What about when I get my flu shot every year? It says I can get GBS, right? Can I get GBS? What about GBS? Well, funny-looking student in the back row. the link between vaccines, flu shots probably especially because they're most in the news, and GBS is, at the very least, controversial. I've included a short statement here from the medical reviewers within the UpToDate Literature Review Service. Though the data suggests that maybe in some years there may have been some kind of relatively small, statistically significant rise in GBS compared to what GBS risk would be for the normal population, the risks of getting flu and the morbidity and mortality of flu and the risks of diseases that could be prevented by other vaccines are greater to most in the medical community than would be the risk of GBS. The take-home message here, as you work with people within the medical community, you're probably going to find most of them feel that the benefits of vaccination outweigh the risk of GBS. Parkinson's disease is a very popular, for lack of a better word, movement neurodegenerative disorder that is caused by a loss of dopamine-producing cells within the substantia nigra of the brain. Now remember from A&P that dopamine and acetylcholine work opposite each other to create smooth movements and muscle movement fluidity. Without dopamine in that equation, movements become very discoordinated and almost have a robotic or ratchet-like quality to them. These characterize Parkinson's disease. Now, what causes the neuronal death specific to the substantial nigra? Well, that's been a heck of a lot of study and research and time. And I present here a kind of conceptual model. It was a great graphic, basically trying to explain the possible mechanisms of neuronal cell injury that have been under research thus far. I will give you a hint right now, not testable. The whole reason I put this information here is to show that there's a whole heck of a lot of competing theories with regards to why these dopamine cells are lost. Two of the main ones involve induction of apoptosis or some other cellular process that then induces necrosis of the substantia nigra. However, as of right now, these are just theoretical explanations. So what happens when someone comes into your clinic and they're complaining of movement disorders? Well, you're going to look for very specific things such as bradykinesia, a resting tremor, when they're shaking even as they're resting. And it looks a lot like this. Muscle rigidity, and the classic change in a Parkinson's patient's countenance is what's called the mask-like face. In our face, we have tons of little muscles that make your face do all kinds of weird things all the time. Without the presence of dopamine, that normal, very slight change in countenance that we see in each other's faces all the time is no longer present. Parkinson's disease is characterized clinically by a mask-like face. Now you might think, hey, I've got one of these patients, I'm working with them, we're going to just scan their brain, look at the substantia nigra, and diagnose things! But actually, Parkinson's disease can pretty much be diagnosed based on the patient's clinical presentation and their response to orally supplemented dopamine. If that improves their symptoms, well, looks like a duck, walks like a duck, it's probably Parkinson's. Now, you may see imaging done in this patient population, but that's because many patients with Parkinson's will develop collections of proteins that are called Lewy bodies. Lewy body protein deposition in the brain can be its own pathology all by itself, called Lewy body dementia, but it's also a relatively common finding in patients with Parkinson's disease. Now, the exact connection of why these two coexist is not yet known, but it's common enough that you may see these patients have brain scans for that purpose. Alzheimer's disease is a form of dementia. Alzheimer's to your patients may come out sounding like this. I got this is the old timers. Yeah, old timers. That's their way of saying Alzheimer's. Same disease. The patho in Alzheimer's involves the formation and deposition of abnormal proteins that are neurotoxic. Tau protein, the more recently discovered protein, is proven to be neurotoxic. However, beta amyloid is thought to be so as well, though the research is not so strong on this. Just like other neurodegenerative diseases, there's probably a genetic profile that contributes to more susceptibility in some individuals rather than others, and that still has yet to be fully researched. Now, one of the things that really is interesting about Alzheimer's, as well as other forms of dementia, is that in almost every case, there are documentable vascular changes, cerebrovascular changes, suggesting that chronic subclinical hypoxia, subclinical poor blood and oxygen delivery may play a role in this disease. Though memory impairment is the most common initial presenting sign for Alzheimer's and a lot of other dementias, one thing you need to be clear of is that people that come in with memory impairment to your clinic need to quickly be discriminated or categorized between either having dementia versus delirium. And there are clinical tools that you can use to help discriminate these two things. Though Alzheimer's is the most common type of dementia, other dementias exist and all will show some degree of change in the central nervous system, specifically the brain and the brain structures. This chart here is not meant to be memorized. It's meant to illustrate the point that common changes found on brain imaging, such as MRI, can be common to more than one form of dementia. Amyotrophic lateral sclerosis, more commonly, at least in the non-clinical population, goes by the name Lou Gehrig's disease. Now, Lou Gehrig was diagnosed with ALS, lordy, a long time ago. More commonly, it's associated with a very famous physicist, Dr. Stephen Hawking. Amyotrophic lateral sclerosis really is one of those medical terms that it's a good idea to try to break down into its respective parts. This is a great exercise to do with this condition. It tells you exactly what's going on, and it helps get you in practice for doing that with other medical terms that you will undeniably come across in your professional career. ALS, also known as Lou Gehrig's disease, is a pathology concerned with progressive atrophy of motor neurons. Think motor only, no sensory loss. Cognition remains intact. This is a motor disorder, and much like other neurodegenerative disorders, it too comes in varying shades or subtypes. Some patients may have a more aggressive form of ALS, and subsequently a worse prognosis, worse disease trajectory, while other patients may have a relatively mild, form of the disease and live a relatively long life. Stephen Hawking outlived his 2-year prognosis by decades. And even with as much celebrity stature as this disease has garnered, we still have no clear mechanism defining the underlying pathology of what's going on and what initially sets off this loss of motor neurons, much less why some patients would have a relatively quick decline versus other patients having a relatively long trajectory of their disease and a slower decline. Okay. Even though I'm talking about all these neurodegenerative diseases, you would be right to say, wait a minute. Degenerative disc disease is not a neurodegenerative disease. Okay, you got me. I could have just as easily have thrown this in the musculoskeletal lecture. The discs within the spine are probably the best place in the body to apply the wear and tear theory with regard to aging and age-related changes. Here's why. They're very hypovascular. So they don't really have the healing mechanisms in place that the rest of our body has, which would have the benefit of blood flow and oxygen and nutrients. Therefore, discs are, through the lifespan, and more so as we get older, at risk for degeneration. And depending on what source you read, almost all of us will have some degree of disc degeneration if we live long enough. The pictures here summarize the type of disc degeneration. Some of them are without clinical symptoms, others can produce clinical symptoms, and the most common clinical symptom for disc degenerative disease is pain. But what type of pain? Well, there's different types of pain. What kind of pain is this? Should I tell you? It rhymes with blurrotraffic. Huntington's disease is a very specific autosomal dominant disorder whereby a mutated gene, the HTT gene, produces a protein that is neurotoxic to some brain cells. This disease is a slow onset disease that typically doesn't occur until later in life. One of the reasons for it continuing generation after generation after generation is the fact that individuals are not diagnosed till they are well after childbearing age. The neurons most affected are in the caudate nucleus and the putamen within the striatum of the base of the brain. If you look at the clinical presentation listed here, you could easily guess that this is a movement-related disorder, kind of like a Parkinson's. Okay, it's fair to think that, but even though a lot of the outward or gross manifestations of this disease are motor in nature, don't be fooled. Patients with Huntington's disease will have, in addition to motor movements, cognitive impairments as well. There isn't a cure for Huntington's disease, but genetic counseling can be done for those individuals affected. In addition to that, because the locus or site of the Huntington's gene is well mapped and verified, it also makes it a good candidate for gene editing therapy, of which we are now in that realm. CRISPR is an acronym for the most specific, precise gene editing tools current medical science has available to us, and Huntington's disease is one of the best possible candidates for CRISPR gene editing research.